In 2006, Rebecca Lowson was a junior at a New Jersey high school. She was on the swim team and working hard for her A's and B's. The sore throat she mentioned that Easter Sunday did not stop her shopping, but she missed church the next day. By Tuesday, her low-grade fever had become more intense and her back ached. That evening, she was diagnosed with pneumonia and admitted to the ER. 2 days later, doctors discovered she was infected with MRSA bacteria, MRSA, methicillin-resistant Staphylococcus aureus. Even then, no one was too worried. She'd been on the right antibiotics from the start, but she continued to slide. Over the next few days, more drugs went in, but her lungs began to look more and more like Swiss cheese as the bacteria continued to reproduce. Eventually, a small chest tube had to be inserted, and then another, and then a tube in her airway to keep her breathing. And then she crashed. The ER team resuscitated her, but after that, they had to keep her sedated. For a while, she could squeeze her mother's hand, and once she even tried to speak. But as the months wore on, she grew weaker and weaker. More tubes and lines were inserted, and she spent much of her time on a cooling blanket to reduce the fever. Nearly 4 months after she first mentioned that sore throat, she died. Here's a different case. Writing in the journal Clinical Infectious Diseases in 2009, 3 New York doctors described a strain of the bacteria Klebsiella pneumoniae, which they called pan-resistant, because it was immune to all the drugs which would normally kill Klebsiella. There are chemicals which can kill this strain, but not without also killing the patient. The doctors described the death of a 67-year-old man overwhelmed by pan-resistant Klebsiella he had caught in their hospital. And then they concluded, "We had no effective treatment to offer." It may as well have been the pre-penicillin era. Here's a third case. In 2011, a patient was transferred from a hospital in New York to the National Institutes of Health Clinical Center in Maryland. This is one of the leading hospitals in the world. The patient was known to be infected with a strain of Klebsiella resistant to some of the most potent antibiotics known. She was immediately isolated in a private room. Visitors had to wear gowns and gloves. She spent a month at the hospital before being released. A month later, a second patient went down with her bug, and then after that, a new patient each week. Altogether, 18 patients got infected during that outbreak, and 6 were killed by the bacteria. It turned out some patients got infected by contaminated ventilators, even though they were rigorously cleaned. Other patients were probably infected by being close to people who had the bug and weren't sick. And some people got sick because they shared the intensive care unit with other sick people. MRSA and pan-resistant Klebsiella are creations of modern medicine. Rebecca and the 67-year-old and the people in the Bethesda hospital died because many of those who had caught Staphylococcus and Klebsiella before them had been treated with antibiotics. That includes many of us. These miraculous drugs worked by decimating the populations of germs which make up the infection. By chance, some patients have a few individual germs less easily killed. And that survival advantage gives them the edge in our pharmaceutical age, and so they spread on from treated patient to infect other people. If those new infections are also treated, the resistant bugs get another boost and on they march. As this evolutionary game plays out, the germs acquire even strong resistance, often against a wide spectrum of drugs. By the time Rebecca and the 67-year-old and the people in the Bethesda hospital became infected, it was not with strains of Staphylococcus and Klebsiella that would once have been easily controlled by drugs. Instead, the strains dealt to them were highly adapted to our pharmaceutical toolkit. Had these people caught their infections in earlier years, or had other patients earlier in the infection chains be treated differently, those people would likely have survived. Where do these resistant bacteria, these resistant bugs, come from? Well, many of our best antibiotics are actually compounds secreted by bugs themselves to kill other bugs. It's a brutal competitive world out there. Bacteria have been trying to kill each other with chemicals for billions of years. Many bugs have only survived by evolving resistance to those chemicals. So drug resistance is often out there in nature anyway. Antibiotic resistance was recently found in bugs living in underground caves isolated from the surface of the earth for 4 million years. Some resistance is new. It can arise by mutation within an infection. Some types of pathogen can get their resistance genes from other bugs, often very unrelated to them. So for example, if you have a harmless bug in your gut with a resistant gene, an invading bug that makes you sick can grab that resistant gene and so become resistant itself. In fact, drug resistance almost always evolves. It's so easy, it is actually amazing when it does not evolve. And there are a few cases of that. For instance, the bacteria that causes syphilis is still killed by penicillin long after penicillin resistance is common in other bugs. And despite widespread use of chloroquine in India, it still works against 5X malaria. even though chloroquine is now useless against other types of malaria in India, and chloroquine resistance is common in Vivax patients in other parts of the world. I would love to know why resistance has not evolved in those cases. If we understood that, maybe we could stop it happening elsewhere. Much of modern medicine relies on drugs to kill bugs, and most of the time those bugs evolve resistance. What are we going to do as drug-resistant bugs become more and more common? In the next video, I'll talk about ways to manage resistance evolution. But I think we also have to start to think hard about ways to treat infections that don't rely on quick drug kill. Instead, we need to think more about stopping people getting infected in the first place. That's essentially better hygiene and vaccines. And we need new bug-proof surfaces on medical equipment. And we need to pay attention to other ways of making people healthy, treating symptoms, using antibodies, using viruses against bacteria, using bacteria against bacteria. In short, we need to move beyond thinking that drugs are magic bullets. That thinking is so last century. Drugs were magic bullets. They aren't now.